next talk is by Jordi Mancebo about pressure support ventilation.
Thank you, Andres. Good afternoon, everybody. Here you can see tracings of an EMG of the diaphragm, an esophageal pressure, airflow, airway pressure, and tidal volume in a patient ventilated with pressure support ventilation. And here in these vertical lines, red vertical lines, you can see the beginning and the end of the inspiratory muscle effort as evaluated from the EMG signal. And these blue arrows indicates the real cycling of signal with this ventilatory mode, which in this particular case is a cycling of criteria at 25% of the peak inspiratory flow. Of course, there are a couple of other characteristics with pressure support ventilation, which are the triggering here, and also the pressurization phase, where the ventilator maintains a constant inspiratory pressure as previously set by the caregiver. And all these characteristics, the triggering phase, the pressurization phase with its pressurization ramp here, and the cycling of criteria all influence patient ventilator interactions, breathing pattern, and inspiratory muscle effort. And I'll go through this briefly in the next following minutes. In this investigation, Chiumello and co-workers studied an assorted group of patients, excluding those who had chronic obstructive pulmonary disease. And these investigators ventilated these individuals with two different levels of pressure support, 5 and 15 centimeters of water. The triggering was set at 0.5 liters per minute. It was a flow triggering system. The cycling cough was at 30% of peak inspiratory flow, and the external PIB was 5 centimeters water. And they studied different pressurization rates from 1 to a very rapid, which you can see schematically here. So since the very beginning of the inspiration, you have a rapid and relatively high peak flow, and the pressurization rate is very quick, and you have this sort of a squared airway pressure tracing. And this would be a very low pressurization rate, where you see that after triggering, the peak inspiratory flow happens some milliseconds later in comparison with this previous one to your left. And again, here you can see how the airway pressure profile is very different in comparison to this to your left. Just in this individual, you can see that there are no major differences in breathing pattern, which is shown here in terms of respiratory rate or TIT tot or tidal volume. Nevertheless, there is an important, a marked difference in inspiratory muscle effort as evaluated by the pressure time product of the diaphragm. And here in this group of individuals, and in both levels of pressure support, the low level of pressure support and the high level of pressure support, they observed a sort of U-shape pattern in the inspiratory muscle effort, here in the vertical axis, evaluated by the pressure time product of the respiratory muscles, and showing that the lowest pressurization rates were associated with the highest level of inspiratory muscle effort, and this inspiratory muscle effort was minimal at these high levels of pressurization, and it tended to increase slightly with the very high pressurization rates of the system. And also this particular shape of the inspiratory muscle effort was nearly the mirror image of the dyspnea sensation in these patients. So the patients felt very dyspneic when they were ventilated with this low pressurization rate, and felt also dyspneic and uncomfortable when the pressurization rates were maximal. Another aspect related with pressure support ventilation is the sleep issue, which was alluded to by previous speakers in the session that we had before. And in this investigation by Saiparta Sarati and his co-workers, the authors hypothesized that the sleep is more fragmented during pressure support ventilation because development of central apneas. And to demonstrate this, they analyzed 11 ventilator-dependent patients that were ventilated with this particular machine, which has a relatively low pressurization rate with, for pressure support, and relatively low cycling cough criteria, which is about 5% of the peak inspiratory flow. And these patients were first ventilated with assist control mechanical ventilation with a tidal volume set at 8 mL per kilogram and a respiratory at a backup rate 4 breaths below the assisted rate. And then these patients were switched to pressure support so as to get the same tidal volume. And then they still studied pressure support by adding 100 mL of dead space. Here they are the mechanical characteristics of the respiratory system of these individuals, and you can see that there is a pretty high airway resistance in this group of individuals, and these are the average pressure support levels to get this tidal volume. No differences in sedatives in these individuals, and more or less what they observed was that after a certain period of time, patients ventilated with a level of pressure support giving 8 mL per kilo tidal volume, they developed long apneas and some inefficient efforts. Well, don't know what happened here. There's a mystery of informatics. But here up there you can see the number of apneas per hour. Please believe me that this is apneas per hour. And in this upper part of the cartoon, you can see that when patients were ventilated with assist control, there are no apneas at all. And some individuals ventilated with pressure support, not all of them, but some individuals exhibited central apneas. And again, if you go down there and you looked only to this group of patients who developed central apneas, and when these individuals were ventilated with pressure support plus 100 mL of added dead space, thus increasing the end-tidal CO2, the apneas disappeared. Again, this is another interesting study by John Hotchkiss and John Marini's group, and this is a study, a bench study trying to analyze the dynamic behavior of pressure support in a leak-free system. And the authors analyzed different mathematical models which resemble different changes in peak inspiratory flow, different cutoff values for the switch to inspiration to expiration, varying inspiratory resistances and varying respiratory rates. And these they tested the model in a bench, with a bench test, with a test lung, and what they observed was that in the setting of airway obstruction, pressure support ventilation is accompanied by marked variations in tidal volume and end expiratory alveolar pressure, even if the patient efforts doesn't change. So, and they concluded that instability worsens by factors increasing the time constant. And I think that this is clinically relevant because this fits very well to patients with chronic obstructive pulmonary disease who are ventilated with pressure support. And this may happen, for instance, here with an individual who had a very severe COPD with relatively normal respiratory system compliance and a very high airway resistance. And you can see how this patient is ventilated exactly with the same levels of pressure support. here about 15 centimeters or 12 centimeters water above PEEP, above external PEEP, about 5 centimeters water. And the only difference between these two settings is the cycling cough criteria. So here to the left, you have a cycling cough criteria for pressure support at a very low flow rate, 5% of the peak. And here to the right, exactly the same machine, the same ventilator, the same patient, but with the cycling cough criteria at 45% of the peak inspiratory flow. No, we used a machine in which we could adjust these different settings. And here to the left, you see how there is a major patient ventilator asynchrony. If you look at the airway pressure tracings, you'll see that the respiratory rate in the machine is about 17 breaths per minute. However, the intrinsic respiratory rate of the patient, you see here plenty of wasted inspiratory effort, which are missed, probably because the tidal volume here is quite high. And the same patient, when simply the cycling cough is changed to this higher level, you see that every inspiratory pressure can be captured by the machine, and there is only one inspiratory effort in this time frame, and the total respiratory rate seen by the ventilator is virtually the same intrinsic respiratory rate of the patient. And you see here that there is a major decrease in tidal volume, conceivably indicating a decrease in pulmonary hyperinflation. Again, this is a more recent work analyzing new and sophisticated triggering and cyclic cough mechanism for a pressure support ventilator. This is a nice physiological and clinical study done by Prinianakis and his co-workers. And with this new unsophisticated system shown here under the heading A, the machine, what it does is offsetting and delaying the actual flow signal, which is this plaque tracing. And by offsetting and delaying this flow signal, the machine generates another electronic signal, which is this dotted line, which crosses the actual expiratory flow, and this is used to trigger the machine, either this one or the usual inspiratory flow setting, whichever comes first. And the inspiration to expiration switch is still determined by a conventional decay in inspiratory flow, or it's determined by this electronic signal, this dotted line which you see here, which is proportional to inspired volume. And they tested this new system with a conventional one, which is shown here, and this is a conventional triggering with a flow mechanism, and a 25% cycling cough criteria. This is the Drager Ebita 4 here to the right. This is the Vision Respironics ventilator to the left. And they did two studies simultaneously. First, a bench study with different inspiratory, with different levels of dynamic hyperinflation and different levels of inspiratory drive. And what they observed was that in the bench model, the new system performed much better than the conventional one, but in the 12 patients in whom the authors compared these two systems in the clinical settings, the differences were really minimal, and what they observed was that with the new system, the number of ineffective inspiratory efforts was significantly decreased in comparison with the conventional one. This is what you see here to your left. Nevertheless, the price that they had to pay is that a significantly major or high number of auto-triggered breaths when the patients were ventilated with this new sophisticated ventilator having this so sensitive triggering mechanism. So you have to keep an equilibrium between a very high sensitivity, so decreasing the number of inefficient efforts, but perhaps paying the price of undesirable and auto-triggered breaths. This is another investigation in which the authors wanted to analyze whether or not pressure support ventilation could be controlled by transdiaphragmatic pressure. And in this study, the detection of the inspiratory effort, either by a signal in pressure or in airflow, and the pressurization during the full inspiration rely upon the online detection of variations on transdiaphragmatic pressure. And the expiratory flow triggering is identical to conventional pressure support. So it's a conventional cycling of from inspiration to expiration with a flow signal. This is a study done in volunteers and in different conditions with normocapnia and hypercapnia. And again, you can see here what happened during spontaneous breathing with in hypercapnia, and during this pressure support controlled via PDI with this new system. And what the authors observed was that with this pressure support driven directly by the transdiaphragmatic pressure signal, there was a decrease in inspiratory muscle effort, which you can see easily here in comparison to your left, and without abnormal triggering effects or attempts. And again, this is just to finish. This is another interesting study done a number of years ago by Jean-Paul Viale and co-workers, looking at the time course of respiratory muscle unloading during the switch from spontaneous breathing here to your left to a certain level of pressure support ventilation here, about 12 centimeters of water in ventilator-dependent patients. These were, in fact, all COPD patients. And the important thing here is that the decrease in drive and inspiratory muscle effort doesn't occur instantaneously, but it does take several breaths, between 7 or 10 breaths, to achieve a full equilibrium. And perhaps this particular behavior of this incapability of instantaneous adapting the respiratory center controllers to this instantaneous inspiratory assistance perhaps might explain why, for instance, synchronized intermittent mandatory ventilation didn't work when it was used to wean patients from mechanical ventilation, because it's unable to provide permanent unloading of the respiratory muscles because of permanent changes in the levels of assistance. So just to conclude, pressure support ventilation is a widely employed mode. Its clinical use is really very simple, and it's quite easy to implement at the bedside. And this is good news. Nevertheless, the working principles are very complex, and this, together with the settings, the proper adjusting of the respiratory, the levels of assistance, may profoundly influence the patient-ventilator interactions. Thank you very much.